We keep repeating that breast cancer treatment is multidisciplinary. We look at the locally the breast, regionally the axilla and supraclav, and then systemic. We target the whole body. So it's thought to be that axilla has surgery has prognostic and therapeutic effect. But then, as we increase our knowledge, we know, yes, it has a very important role in prognosis and aiding the tailoring the further systemic therapy, but we know that it might not affect the survival. And because of its morbidities, we came up with the concept of de-escalation of surgery. So the NSABB4 is the first trial that challenged the axillary surgery. In this trial, in the 1970, they took patients with operable breast cancer and with node negative and node positive disease and randomized them into radical mastectomy, total mastectomy with radiation. And for node positive, either they go for radical mastectomy versus total mastectomy and axillary lymph node and axillary radiation. 25-year survival data showed that there is no difference in the overall survival of the three groups. Yes, the total mastectomy group who did not receive any targeted axillary treatment, they had for 19% local recurrence rate, however, or regional recurrence. However, it did not affect their overall survival. And then we moved away from trying to omit the axilla. We practiced axillary dissection for almost 25 years until the Z11 trial and the IBGS trials came. So the axillary management in the setting of upfront surgery is my next topic. First, if a patient discovered to have an axillary node dissection, axillary lymph node based on ultrasound and biopsy finding, and will undergo upfront surgery, the standard of care until now is axillary lymph node dissection. There is a single prospective trial done at Memorial Sloan Kettering showed that even those patients, if you do for them sentinel lymph node, you can spare them in 70% of the patient, or sorry, 50%, you can spare them axillary lymph node dissection. Now we will talk about patients who are found to be positive positive on sentinel lymph node. There are two major trials that we always talk about, the ECAZAG Z11 and the IBCSG 2301. Both of them were phase 3 clinical randomized trials. They both looked at omitting the axillary lymph node dissection in patients with node positive disease based on sentinel. In the Z trial, they included only patients undergoing breast conserving therapy, and they included patients with gross node with macroscopic lymph nodal metastasis. In the both studies, there was no radiation to the axilla whatsoever. In the IBCSG study, that was both studies had their 10 years follow-up recently published. They did surgery, BCT, and mastectomy. Even though mastectomy was underrepresented in this study, only 10% of the group had of the group where underwent mastectomy, and sentinel versus no axillary lymph node dissection. They included only micrometastatic disease. The overall survival and the disease-free survival for both groups were equal in both studies. So these two studies changed the practice and actually changed the guidelines. And now we treat patients with sentinel lymph node positive with lymph nodal metastasis. We can safely omit axillary lymph node dissection. Along with the Z11 trial, we have the AMAROS trial, which is a similar design. However, it added, instead of axillary lymph node dissection, radiotherapy to the axilla. The study group concluded that axillary lymph node dissection and radiotherapy after a positive sentinel lymph node provided excellent and comparable axillary control. Moreover, axillary radiotherapy resulted in significant less morbidity, which is namely lymphedema. And recently, in late 2020, the Breast Cancer Center Oncology Group have updated their guidelines, and they advised for that axillary lymph node dissection may be avoided in patients with clinically negative axilla who have micro or macro metastasis to no more than 2 sentinel lymph nodes, who are at least 40 years old and in lesions less than 3 centimeters, and will undergo breast conserving therapy and whole breast radiation. The question comes, what about patients who will undergo mastectomy? Shall we still do axillary lymph node dissection? This is still a question open to be answered, and we take them case by case and discuss them all in our multidisciplinary tumor board. And now we will talk about patients who were found to have node positive disease, but will undergo upfront surgery. We all know that a lot depends on the tumor itself. The rate of response and conversion to be complete pathological response varies between 40 to 70%. Can we spare those patients axillary lymph node dissection? There are challenge in this scenario is the false negative rate. So there are 3 major feasibility studies. They are phase 2 trials, single arm, all assessed the sentinel lymph node in the setting of post-neoadjuvant. The patient who were converted from clinically N1 to N0 and receive neoadjuvant, you assist them with clinical and radiological examination of the axilla, and then you send them or you operate in them with sentinel lymph node. The Sentinel trial, the Sentinel FNAX trial, and ACAZAG Z11 trial. The identification rate varied widely between the studies, and the false negative rate was high. And the complete pathological response, as I mentioned, it varied between 70 to 40%. So the question is, how can we improve our false negative rate and identify those cohort of patients who can safely we omit the axillary lymph node dissection? Even though the identification rate and the false negative rate varied across the study, however, the consistent finding was if you use a dual technique and if you retrieve more than 2 to 3 sentinel lymph node, then the rate of identification and the false negative rate falls as low as 4%. So this is a table from the Sentinel FNAX study, and we see that if the number of sentinel lymph nodes that was removed more than 2, the false negative rate falls to about 5%. And in cases of dual technique or dual tracer use, the identification rate, the false negative rate falls to 5.2%. And in a meta-analysis that was published recently in the British Journal of Surgery, they identified 13 studies that addressed the same question, which is node positive on post-neoadjuvant who were converted to node negative. The false negative rate with dual mapping was about 11%, and it's highly correlated with the number of lymph node removed. It was when one lymph node was removed, it was 23%, and if more than 2 sentinel lymph node, it falls down to 4%. And the group concluded that sentinel lymph node after neoadjuvant in patients with biopsy-proven node-positive breast cancer is an accurate and reliable, but require patient selection and optimal surgical technique. So we have a feasibility study. Unfortunately, there is no follow-up data or safety data documenting that it's safe to omit those patients. There are some retrospective trial or a cohort of patients that they showed no increase in local recurrence or in overall survival, no difference. However, no clinical trials address the same question. There is one single prospective cohort of patients that documented that sentinel lymph node was safe, was avoided in 48 of patients. Unfortunately, the study did not give us any follow-up data. So still, this is a question to be answered. So to improve our detection rate, Claude et al. Came with a concept of targeted axillary lymph node dissection, which means excision of the clipped lymph node plus doing a sentinel lymph node. It improved the false negative rate markedly. In his cohort of patients, Claude et al. Reported a false negative rate of 1.4%. There are multiple ways of doing targeted axillary dissection. Wire localization, which is often difficult for us as a surgeon and for our radiology colleagues. Wireless localization using radioactive seeds or scout localization, and tattooing. As I mentioned, it improved the false negative rate markedly. And it's easy to it's very easy, but still the safety data needs to come out. So in the setting of positive sentinel lymph node, positive that was converted to N0, we have a feasibility studies that documented we have a good false negative rate, but no safety data. Now, what do we do with positive sentinel lymph node post-neoadjuvant? It's a question that often comes up in our tumor board meeting. The standard of care is doing axillary lymph node dissection, but shall we treat patient with isolated tumor cell or micrometastasis as patient with nodal metastasis? Are we really helping them by doing extra surgery? Still, this need to be question to be answered. I think still sentinel post-neoadjuvant for inflammatory breast cancer or node N2 disease is still, they are both underrepresented in the study, and I don't recommend it. So, in summary, among patients with limited sentinel lymph node metastasis treated with breast conservation and systemic therapy, the use of sentinel lymph node alone compared with axillary lymph node dissection did not result in inferior survival. And in patients with positive lymph node undergoing neoadjuvant chemotherapy, the accuracy rate of sentinel lymph node is enhanced by dual technique, removal of more than 3 lymph nodes and removal of the clipped lymph nodes. And finally, axillary lymph node dissection remains standard of care for node positive undergoing mastectomy and in the setting of positive sentinel lymph node post-neoadjuvant chemo. Future studies assessing the axilla, there is the SOUND trial that assess that you omit even sentinel lymph node in cases of clinical N0 disease. We have the CINOMAC study that study the positive lymph node in the setting of upfront surgery, macrometastasis in the setting of upfront surgery, and especially mastectomy. And we have node positive in the setting of chemotherapy patient. There is the TAXIS trial, which is the TAXI and the Alliance, they have both a similar design. However, the TAXI is multinational trial, the Alliance is North American trial. And we are waiting for the results so we can save our patients more axillary lymph node dissection. And by this slide, I conclude my talk. Thank you very much, everybody. Thank you.
Thank you very much, Dr. Lolwah. Very, very interesting journey through history of the axilla, and well done and well presented. And we might end up later on in a situation where the rule is not to do anything to the axilla and the exception is to do something. Very interesting. It's also my pleasure to introduce Professor Mehra Gulshan from Yale Cancer Center from the across the Atlantic. Dr. Mehra is going to talk to us about a current update in breast cancer surgery. And Dr. Mehra does not need actually any further introduction. He is a well-known figure to all of you. Please, Dr. Gulshan.
Thank you very much for having me here today. It's such an honor. I wish I was there in person with you, and inshallah, one day when COVID gets better, we'll be together again. I really like to thank the organizers